All right, friends. Hope we're doing well. We are looking at the article Why Doctors Should Intervene by Terence Ackerman. It starts on page 71. You should have read it already. You should have just done the, beneficence today or autonomy tomorrow. And I'm going to see if I can do this quickly. It might spill into another video, but if I go slow, just turn it to speed and a quarter, speed and a half, and burn through me. Or just go to 0.75 and really soak it in. But the argument for patient autonomy, I think, is pretty clear, right? Humans have the right to make choices for themselves, for better or worse, as long as they can think for themselves, as long as they can deliberate, as long as they have free choice, as long as they can compare it to their own long-term goals and values and act consistently. And we've seen very strict articulations of autonomy, include this idea of the authenticity condition, right? Which is that you have to actually know your own long-term goals and values, as opposed to children or teens who largely inherit them from their surroundings, their cave, their parents. But the argument today in Why Doctors Should Intervene says that actually the right relationship between healthcare workers and patients is not one of, say, non-interference. Yeah, this idea, this almost fetish for patient autonomy, we'll call it, kind of portrays the idea that the doctor, if he's doing his job well, acts like a Google search result, right? The patient comes in, Googles their symptoms in, and the doctor just spits out, this is your condition, these are the options, you make a choice, without really influencing, right, the patient in any way. Whereas, influencing the patient, as we've been talking about, it often might mean withholding information, coloring it, not telling them the full truth of their condition, because as we've seen, doctors have a long precedence of saying, if we think that disclosing to a patient that they have cancer or they might die from a procedure is going to cause them direct harm and hinder their life and prolonged health, then we are justified in invoking therapeutic privilege, aka lying or misleading them, right? Ackerman pushes back against this and says, let's look at the idea that does non-interference really respect patient autonomy? And I'm just going to read a little bit of it. Like I said, we're going to get through this together. He says, does non-interference really respect patient autonomy? I maintain that it does not, because it fails to take into account the transforming effects of illness. Autonomy, typically defined as self-governance, has two key features. First, autonomous behavior is governed by plans of action that have been formulated through deliberation or reflection. This deliberative activity involves processes of both information gathering and priority setting. Second, autonomous behavior issues intentionally and voluntarily from choices people make based upon their own life plans. This should seem very familiar with our talk on autonomy and being able to take in information, process, deliberate it, compare it to our own goals and values, identify our own goals and values, and see which course seems most efficacious, and also to act freely, right? The independence condition, which says that you're not under a constraint, you're not being threatened, you're not, sleepwalking or under the influence of something. Okay, stop me if but various kinds of constraints can impede autonomous behavior. So saying, yeah, it's fine that we're free to act and make choices and deliberate on things, but aren't there things that hinder that? There are physical constraints, confinement in prison, for example, where internal or external circumstances bodily prevent a person from deliberating adequately or acting on life plans. Like if you're in prison or stuck in a third world country or in a rural place with no doctors or hospitals, like do you have the same range of medical options available to you than someone else? No, you have constraints on your freedom to choose and act. And we're very lucky in some ways in Madison that we have so many hospitals, so many urgent care facilities, so many resources that many places don't have. So physical constraints impede our autonomous behavior, yeah? Cognitive constraints derive from a lack of information or an inability to understand the information. A consumer's ignorance regarding the merits or defects of a particular product fits the description. Psychological constraints, such as anxiety or depression, also inhibit adequate deliberation. So if you're depressed, you're not thinking clearly, right? You have constraints preventing the full range of you acting upon and realizing your goals and values. Same with irrational denial of circumstances, right? Or an irrational hope for things. Like I remember, no, today's not the day for that story. It's an in-person sort of story. But you get what I'm saying. And lastly, there are social constraints, such as like societal roles or institutionalized roles and expectations. A woman's place is in the home. The doctor knows best. Or, you're a child and we're going to look at a couple cases here, and your parents want you to do something, and because you want to please your parents more than respect your own wishes, right? There's cases where in order for a child to undergo a procedure, they're going to become sterile and lose their right or their ability to have children. And the parents want to make that choice for the kids, right? When the kid really, has a right to say, like, no, I might want to have kids later, uh, that sort of thing. Or, in some cultures, I'm thinking one or two Asian cultures like Korean Americans, you kind of you don't make decisions for yourself. You make the family let the family make them for you, kind of, right? And they have this idea called nunki, where you don't actually. So, like, this is an interesting element of truth telling, right? That it is actually culturally relative. And whereas most of us would want to know the full truth of our condition, let's say we had cancer or something, terminal. Some cultures, particularly Korean American, there's an article in here somewhere. You'll have to find it. Talk about how, actually they tell the family, and the family kind of like intuits to the person without actually telling them. And for them, that's more respectful. Whereas many of us are like, no, just give me or we think we are, give me the facts and let me sort them out, right? We'll see if we actually are or not in the end. Okay. So basically, Ackerman's pointing out all of these things that hinder our ability to make choices for ourselves. And one of the thrusts of this whole article is that, like, patients don't go to the doctor unless there's already constraints on their autonomy, right? Like, most of us avoid going to the doctor unless we can't do the things we normally want to do, right? So it's almost as if, like, it's an implied constraint, either physical, your health, your body, your mind. And so he says at the bottom of 72, the most obvious impediment is that illness interposes the body or the mind between the patient and reality, obstructing attempts to act upon cherished plans. An illness may not only temporarily obstruct long-range goals, it may necessitate permanent and drastic revision in the patient's major activities such as working habits. Patients may also need to set limited goals regarding control of pain, alteration in diet, and physical activity. So, a couple examples he gives. I'm going to go through these pretty quick and maybe make one or two comments. And, again, hopefully this makes sense. Pellegrino mentions the anxieties created by illness, but also psychological constraints may also include denial, depression, guilt, and fear. I recently visited an 18-year-old boy who was dying of a cancer that had metastasized extensively throughout his abdomen. The doctor wanted to administer further chemotherapy that might extend the patient's life a few months, but the patient's nutritional status was poor, and he would need intravenous feeding prior to chemotherapy, since the nutritional therapy might also encourage tumor growth, leading to a blockage of the gastrointestinal tract. The physician carefully explained the options and risks and benefits several times, each time at greater length. But after each explanation, the young man would say only that he wished to do whatever was necessary to get better. Denial prevented him from exploring the alternatives. So what's going on here? Doctor's like, chemotherapy will give you a couple months. A couple months might be nice for you. No one wants to die. But in order to do chemotherapy, we need to do this nutritional feeding, but it might increase the tumor. It might, so, what do we want to do? The kid, it's kind of like the last one with the woman who goes cyanotic. Wait, yeah, like if the doctor doesn't know what the best choice is, right? How's the kid going to make that choice? Denial was preventing him from accurately deliberating on those two choices. Second criteria, right? Another example, depression can lead patients to make choices that are not in harmony with their life plans. Recently, a middle-aged woman with a history of ovarian cancer in remission returned to the hospital for the biopsy of a possible pulmonary metastasis. Complications ensued, and she required the use of an artificial respirator for several days. She became severely depressed and soon refused further treatment. The behavior was entirely out of character with her previous full commitment to treatment. Fully supporting her overt wishes might have robbed her of many months of relatively comfortable life in the midst of a very supportive family around which her activities centered. The medical staff stalled for time. Fortunately, her condition improved. Oh my Lord. So this is a tough one, right? Here you have a woman who's in remission, right? Uh, Comes into the hospital, has a relapse, refuses treatment. It's just like, leave me alone. I don't want to do this. Because this was inconsistent with her previous full commitment to treatment and recovery, they're like, this doesn't seem like you, right? And so they're using depression as the psychological constraint, saying she wasn't thinking right. She had a psychological constraint preventing her from adequately choosing, deliberating, and identifying her own long-term goals and values. And they stalled, they ignored, they killed for time, and she came around. And so it's one of those questions of like, is it all's well that ends well? Like, depression is a tricky thing. As much as I'm willing to tell most people the inner motivations that govern their life, as you have noticed, uh, one thing you should never, ever, 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 ever do is tell a person that you know what it feels like to experience what they're experiencing. Yeah? Because I promise you, you don't. Right? Uh, and when it comes to things like depression, it's very tricky to know what a person's feeling. Like, I know that, like, me at my lowest isn't even close to what some of my family and friends live with on a daily basis. Um, but I have a stepmother who's like a high functioning, she's a pastor. She's been chronically depressed for 40 years, right? But she functions, she lives her life. Now, are you going to tell me that because she's been depressed for 40 years that she's not acting autonomously, that psychological constraint is preventing her from choosing, deliberating, knowing her own long-term, I'm trying to do these in the camera, that knowing her own long-term goals and values? Well, I think you'd be very reticent to make that case, right? It does seem like the woman in here, they did right by stalling. She came around, got better, right? But what if she just stayed depressed and said, you know what? I thought I wanted to go through treatment, but I don't. I just want you to leave me alone. Are they just going to take away her autonomy and say, you lack DMC, decision-making capacity, right? You're not qualified to. Hopefully you see how tricky this is. Some of these constraints I think are more valid than others. I'll put that out there, right? So one of the things I want you to think about are which of these constraints do we think actually hinders autonomy and the ability to make free choices, and which of it's kind of just more justification for doctors to invoke medical paternalism. Okay, fear may also cripple the ability of patients to choose. Another patient, diagnosed as having a cerebral tumor that was probably malignant, refused life-saving surgery because he feared the cosmetic effects of neurosurgery and the possibility of neurological damage. After he became comatose and new evidence suggested that the tumor might be benign, his family agreed to surgery and the benign tumor was removed. But he later died of complications related to the unfortunate delay in surgery. Although while competent, he had agreed to chemotherapy. His fears, not uncommon candidates for neurosurgery, prevented him from accepting the medical intervention that might have secured him the health he desired. Right? So he just had a fear of surgery, died as a result of it. Social constraints may also prevent patients from acting upon their considered choices. a 12-year-old boy whose rhabdomyosarcoma had metastasized extensively. Since all therapeutic interventions had failed, the only remaining option was to involve him in a phase 1 clinical trial. A phase 1 clinical trial is the initial testing of a drug in human subjects. Its primary purpose is to identify toxicities rather than to evaluate therapeutic effectiveness. The patient's course had been very stormy, and he privately expressed to the staff his desire to quit further therapy and return home. However, his parents, denied the hopelessness of his condition, remained steadfast in their belief that God would save their child. With deep regard for his parents' wishes, he refused to openly object to their desires, and the therapy was administered. No anti-tumor effect occurred, and the patient soon died. Very interesting. 12-year-old boy who clearly has some components of autonomy, right? We don't think young children have full autonomy. Just want to go home. It's like, man, clinical 1 trials, like, but want to be a good kid, please his parents, is that justified? Is that unjustified? Should his wishes have been respected? So we've got a bunch of examples. I want you to think about which of those examples you think are strongest. See if I can see how far we are into this. I don't know. Well, I'm just going to keep going until it shuts, and hopefully we can get done. And so here's the real thrust of this, right? The thrust of this is Ackerman saying the only reason people come to the hospital is because they don't have autonomy. Like, we avoid it at all cost. And so they wouldn't come unless they weren't hoping to have us help them get back to their own normal life. And so rather than restraining themselves so that patients can exercise their autonomy, they retain an illness. Physicians should actively seek to neutralize the impediments that interfere with patients' choices. In The Healer's Art, Eric Castle underscores the essential feature of illness that demands a revision in our understanding of respect for autonomy. If I had to pick the aspect of illness that is most destructive to the sick, I would choose the loss of control. Maintaining control over oneself is so vital to all of us that we might see all the other phenomena of illness as doing harm not only in their own right, but doubly so as they reinforce the sick person's perception that he is no longer in control. The doctor's job is to return control to his patient. But what is involved in returning control to patients? Pellegrino identifies 2 elements that are preeminent duties of the physician. 1, to provide technically competent care, and to fully inform the patient. The non-interference approach emphasizes these factors, and their importance is clear. Loss of control in illness is precipitated by a physical or mental defect. Okay. Sorry to be long-winded. Just to recap, the argument for medical paternalism is that its actual purpose is to restore autonomy. That the only reason people come in is because their sickness, their condition is hindering their autonomy, the ability for they to live their life and carry out their choices and deliberate on them and pursue their life goals and values, right? I think it's a pretty strong argument, right? That we have these, let's see here. We got our conditions, we have these constraints, either physical or cognitive or psychological or social. If we were in class, I would have us go over which ones we think are justified, which ones we think are unjustified. I will probably have the discussion board post be on this. I might change it up. Don't hold me to it. But illness necessarily impedes and prevents autonomy, or no one would need the doctor. Please turn off your Imperial probe droids. Therefore, paternalism as returning control and autonomy to patients, right? The idea that if someone comes in sick, they give you their symptoms, and you just give the 4 options from a Google search and don't influence them or tell them, hey, I recommend this for these reasons versus this, or try to sway them, identifying if they're in denial, if they have blind hope, or if they're fearful, right? Whatever the things are, so that they can actually think things through clearly. We will talk more about this. I'm going to end this conversation, and I'm going to end this conversation. We'll